Today we're going to discuss nasal trauma, which is something that you can commonly see in the emergency department as an ENT SHO. This is just an overview of what we'll be going over during this presentation, a brief introduction, how to assess patients with nasal trauma, and then we'll go over the common types of nasal trauma that you might encounter. This involves nasal fractures, nasal lacerations, septal haematoma, and traumatic epistaxis. We'll also briefly touch on the complications that can occur from each type of trauma, and then a summary at the end. Nasal trauma is very, very common. It can be isolated, or it can also commonly coexist with other injuries, most commonly head injury or C-spine injury if patients come in with multiple trauma. But 50% of nasal trauma is also isolated. In the diagram to the right, it's just a diagram of the different types of nasal bones that you may encounter that could be damaged. When assessing a patient who comes in with nasal trauma, always assess as per the ATLS guidelines using an A to E approach. It's really important to make sure that there's no coexisting more severe injury in the patient. As I mentioned before, commonly head injury or C-spine injury. It's important to make sure the patient is cleared from these points first before the nasal trauma is investigated. When taking a history, as well as all the normal things to be asked, there are some salient points in the history regarding nasal trauma. This particularly involves the mechanism of injury, where the impact was coming from, how hard the force was, in what direction the impact was coming, which could have quite a strong impact on the type of injury that was created, and also the timing of the injury, how long ago did it happen. Don't forget to ask the patient about pain, in particular where it hurts. Ask them if they feel like their nose is deviated to one side or not. Inquire whether it feels like there's any obstruction within the nose, and if the patient's not having a nosebleed when you speak to them, don't forget to ask if there's been a nosebleed prior to presentation. Following history, the next step is to do a thorough examination of the nose. This is some of the equipment you might need to examine the nose. It can sometimes be difficult to come across all these things, especially in a busy emergency department, but in an ideal world, these are the things that you would have to fully examine the nose. A pedicum speculum is very useful for examining the anterior portion of the nose. Alternatively, if you have access to it, fine nasal endoscopy can be really beneficial to examine all the way to the postnasal space and beyond. Headlights are really useful for a wide range of ENT examination procedures, and it allows you to fully examine the nose and other orifices whilst having both your hands free. Metal tongue depressors can be used to examine misting pattern to test for obstruction or deviation, and an otoscope with a large speculum on the end can be really beneficial to look inside the nose as well. The first step when examining any part of the body is to inspect. This also applies to the nose. Be sure to inspect the nose from the front to top and the sides to see if there's any deviation or obvious bony abnormality. The next step is to palpate. In particular, try to feel mobile nasal bones. Feel if there's a fracture line or if there's a step or depression within or around the nose. The next step is anterior rhinoscopy, to look within the nose itself. The easiest way to do this is to push the tip of the nose upwards to look into the anterior nerve. At this point, it's useful to examine for septal haematoma, which is one of the things that we'll come on to discuss later on. If appropriate, test for the olfactory nerve, and then test the nasal misting pattern on a metal tongue depressor. This can be done by holding a metal tongue depressor underneath the patient's nostrils and asking them to blow out, looking for the misting pattern. If the misting is less on one side, it suggests there's an obstruction in that side or deviation of the septum towards that side. If indicated, the patient can also be scoped at this stage. The first type of nasal trauma that we're going to discuss are nasal fractures. These are extremely common and they account for nearly 50% of all facial fractures. Contrary to popular belief, there's no role for X-ray here, and in fact, can confuse the clinical picture. If you feel that any type of imaging is indicated for the patient, then CT would be the modality of choice. Most of these patients will come in with a large amount of swelling to the face and nose, and it can be very difficult to assess exactly what type of bony injury has happened at this stage. After doing a brief examination and examining for things such as septal haematoma, most of these patients are discharged and seen semi-electively in ENT clinic at around 7 to 10 days to assess the injury once the swelling has settled. There's two important things to look for when assessing these patients in outpatient clinic. The first is deformity, objective versus subjective. Subjective deformity is what the patient feels has happened to their nose. How deformed do they think it looks following the injury? Objective deformity is what you as the clinician or somebody as the third party feels has happened to the nose. The second thing to assess is obstruction, whether there's any obstruction within the patient's nose. And again, this can be assessed with misting on the nasal tongue depressor, such as done in the initial assessment. A few salient points with examination of a nasal fracture. When examining the nose, it's extremely important to examine for airway patency by looking into the nose and also by doing the nasal misting pattern. Be sure to check if there's any mucosal laceration around the nose, and these can commonly occur if there's been an injury to the nose or within the nose itself. And when looking into the nose, examine for any septal deformity. The nose, as mentioned previously, 50% of injuries to the nose occur in an isolated fashion, but it's very common to also have injuries relating to the nose at the same time. So don't forget about the surrounding structures. The most common structures that are injured when the nose is injured concurrently are the orbit, the mandible, and the C-spine. And it's extremely important to examine these at initial assessments as well. Important things that may be picked up on examination, such as CSF rhinorrhea, malocclusion of the teeth, or limited movements within the eye, do warrant subspecialist referral. CSF rhinorrhea can be picked up by clear, watery fluid running from the nose, and this can be checked by doing a glucose dipstick test. Nasal secretions will not have glucose. CSF rhinorrhea will. There's some specialist advice that you can give to patients when discharging them from ED before seeing them semi-electively. Advise them to put ice to the nose to try and help reduce the swelling and to elevate the head, especially when sleeping. Advise them about the next steps that may happen once they come back semi-electively to clinic, and there's a number of things that can be done. If the clinician feels that the patient is suitable for manipulation, this can be done under anesthesia. There's a number of different ways to do this. Sometimes it can be done under local with a regional nose block such as the Lignus band, or if the patient is more difficult or if the fracture is more severe, this can be done under general anesthetic as well. The technique for this is to apply firm lateral pressure just below the area of the deformity to the nose with the tip of the finger with the aim of realigning the dorsum. But it's important to note and important to tell the patient as well that this technique is rarely effective for deformities of the dorsal hump. Sometimes this method is not sufficient for realigning the nose, and if there's been an unsatisfactory outcome, either for cosmetic purposes or functional purposes, septo or rhinoplasty can be then performed. Nasal lacerations can commonly occur in conjunction with other facial trauma all on their own. These are notoriously difficult to close due to the 3D nature of the nose, and quite commonly it may be necessary to refer these patients to plastic or Max-Fax. As with any laceration or wound, it's important to thoroughly irrigate the wound first of all, and then close in layers. Absorbable sutures for the mucosa. If you're closing the cartilage, nylon or monocryl is recommended. And then finally for skin, to close with nylon or proline. Undermining the skin may be needed to remove excess tension if you're closing around difficult areas. And some of these defects may need skin grafts under plastics if there is skin and tissue loss. Septal haematoma is something that we mentioned earlier when examining inside the nose. This is an emergency in ENT if you do see it, and it's really, really, really important to examine for this anytime you examine a patient with facial trauma, regardless of whether there's a distinct trauma to the nose or not. Septal haematoma occurs when shearing forces result in a separation of the overlying nasal perichondrium from the septal cartilage itself. This causes the submucosal blood vessels to tear and then causes an accumulation of blood in that newly formed space. When examining the nose from outside, this can be seen as a boggy swelling from the nasal mucosa, and if palpated will be fluctuant. The photograph on the side shows what septal haematoma looks like when looking from the outside, and you can see the red boggy swelling through either nostril. Management of septal haematoma in a timely fashion is extremely important. These should be aspirated or incised and drained under local anaesthetic pretty quickly. Once this has happened, splints or packing can be applied within the nose to prevent reaccumulation of the septal haematoma itself. And when discharging the patient, external splinting shear should be applied for 1 week to support the nose. The diagram below briefly shows how to incise and drain a septal haematoma. The reason that these should be treated in such a timely fashion is due to the quite significant consequences of not treating. If left untreated, septal hematomas can lead to avascular necrosis of the septal cartilage. They can lead to an increased risk of infection and even septal abscess formation, which can then lead on to ascending cavernous sinus infection. They can potentially lead to septal perforation and, at the end of it all, a saddle nose deformity, which is pictured in the photograph below. For these reasons, it's incredibly important to always examine for septal haematoma when dealing with any facial trauma and to treat in a timely manner. Epistaxis, nose bleeding, is something that can occur for many, many different reasons. In this particular presentation, we're going to be focusing on a traumatic cause of epistaxis as opposed to other causes relating to anticoagulation. Traumatic epistaxis usually originates in the ethmoidal arteries, and that's where the bleeding will occur from. Regardless of what the cause is, it's always important to inquire about coagulation status. Patients who are on blood thinners, for example, will have more bleeding than others. Complications of traumatic epistaxis are quite rare, but they can involve hypovolemia, anemia, and other complications occur from packing the nose, such as toxic shock syndrome. Management of traumatic epistaxis is the same as any other management of epistaxis within the hospital, and this will occur in a stepwise management. The usual first aid measures are initiated first, and this can be advised to the patient. You would advise the patient to pinch the nose in the soft part of the nose below the cartilage for at least 30 minutes. If this doesn't stop the bleeding point can be cauterized using silver nitrate. Don't be afraid to use multiple sticks to stop the bleeding. If this doesn't suffice, The next step is nasal packing. This can be done into one or two of the nostrils, depending on how severe the bleeding is. Nasal packing from traumatic epistaxis will usually be done anteriorly, but if needed, can be done posteriorly as well. If the patient is having nasal packing, they will usually stay in hospital for monitoring. The final step and a last resort for extremely severe epistaxis that doesn't settle on any of the previous steps is surgical intervention. Once the bleeding has settled and the patient is being discharged, it's important to give self-care advice such as avoiding picking of the nose and heavy lifting for 1 to 2 weeks. There can be some complications of nasal trauma, and it's always important to look out for these. CSF leak is a common complication, well, not should I say common, but can occur as a complication relating to nasal trauma in addition to facial fractures. It usually occurs following a fracture of the cribriform plate. The patients will present with persistent clear rhinorrhea, which is different to the mucosal rhinorrhea. And the way that this can be tested for is by testing for high levels of beta-2 transferrin in the CSF, or, as I mentioned previously, testing for glucose. This can be done with a urine test strip, and if positive, would suggest a CSF leak. Although this sounds scary, 95% of these will heal spontaneously within 2 weeks, but you should always seek specialist advice regardless. Patients who have nasal trauma can also present with anosmia. This commonly occurs acutely, for example, if the nasal passages are blocked with blood, but can also occur chronically if there's damage to the olfactory structures. Unfortunately, this is unlikely to resolve. In summary, today we've discussed nasal trauma, and we've discussed the main types of nasal trauma we may come off, which include nasal fracture, nasal lacerations, septal haematoma, and traumatic epistaxis. The salient points from today's presentation are: it's always important to consider coexisting trauma, especially head injury or C-spine trauma as well. And it's important that the patient is cleared from this point of view. But when examining, don't forget the other nearby structures as well, such as the orbit or the mandible. Always, always, always check for septal haematoma when examining a patient that has any type of facial trauma, regardless of whether it affects the nose. It's important to look inside the nostrils to make sure that there's no septal haematoma. And if found, this needs to be treated in a timely fashion. If you come across a patient with a nasal fracture that's very severely swollen, don't worry, they can be seen semi-electively in ENT clinic at 7 to 10 days. And if you come across a CSF leak, always seek specialist advice, but most of these will resolve spontaneously. Thank you very much.